Good. So welcome everybody to this quality and safety network. We'll be starting now for our 11th or 12th webinar, I think, 11th. So welcome everybody. Happy you could join us. Just a quick reminder why this network exists. It has been created by HOPE, the European Hospital Federation, and PACS, just to be able to share best practices across Europe. More focused on patient safety and quality of care. And this is why we've been organizing these webinars. You can see that since 2019, we have had 11 topics. All of these webinars are available on our YouTube channel. So if you're interested in any of these topics, feel free to just go and review any webinar you want. And if you have any questions regarding the speaker or the content of these presentations, don't hesitate to contact us. We're glad to put you in contact with every organization that has presented the last few years. I do have a sneak peek for 2022. So today we have a Belgian Flanders presentation, but in May we'll have a presentation about adverse events in France. They have organized a third national incident survey, so that will be the results of that study. Then we'll have Germany, who will present about the critical incident reporting systems they have in use. And by the end of the year, we'll have Belgian Breakthrough Series Collaborative presenting their results in a lot of patient safety topics. So if you're interested, all the details are available and you can already register if you're interested. So for today, there's a lot of countries from all over Europe as usual. So glad you could join us today. And I'll be happily giving the floor to Svin Deneckere, who is director of the Flemish Institute for Quality of Care, and who will be talking to you about how quality indicators are used in Flanders in the health system. So Svin, the floor is yours.
Thank you, Laura. I will now share my presentation. Thank you for this invitation. I hope you can hear and see me well. And then I can start the presentation.
So just to confirm, we can hear you and we can see your slides.
Okay, perfect. Thank you for this invitation to present to you the Flemish Institute for Quality of Care, our context, our goals, our objectives, and procedures and methodology, and also to look at some first results of on our indicators and some future objectives which we have with VIKZ. I think the presentation will take half an hour, 40 minutes, and then we will also be able to discuss some topics if you all have some questions on that. So the Flemish Institute for Quality of Care, VIKZ, Vlaams Instituut voor Kwaliteit van Zorg, was the first time mentioned in the policy note of Minister Van Deurzen in 2014. Where he wanted to set up this VIKZ, this initiative to share common grounds and share objectives on measuring and following up quality of care and patient safety in the various sectors of the Flemish healthcare and residential care. And not only to improve quality of care and to coordinate different initiatives, but also to facilitate transparency, to facilitate public reporting of quality of care within these sectors. As first core objective, thus our main objective was to develop a core set of quality indicators, and it's important to focus on core set. We do not have the objective to develop hundreds, 200s of quality indicators. No, we want to develop these indicators that are most relevant and valid and reliable, and that do say something on actual quality of care. So we want to develop a core set of quality indicators with the sector. This is also very important. Every initiative that we take, we do together, and in a decision, we take these decisions with the sector, and according to a uniform evidence-based methodology. Again, every initiative which we develop is taken together with the sector, and also with a uniform evidence-based methodology. Our secondary main objective is then to facilitate, based on these quality indicators, public reporting of quality of care. And this is by our platform, zorgkwaliteit.be, which I will show you later on. Our third main objective is to coordinate and link different quality initiatives taken on within the regional level, within local level, but also between universities, knowledge centers, and on different policy levels also. To build also a knowledge network on that and to strengthen the dynamics around quality of care in Flanders. Of course, we do want to have also policy impact. We want to support building a future-proof integrated Flemish quality of care policy, and not only discussed it within the Flemish government, but also with other federal entities. And as policy impact, we want to stimulate that our indicators are used for policy support. And then, of course, also we want to stimulate research and training concerning quality of care and improvement. So these are our main objectives. We have these objectives are formulated in an agreement that we have with the Flemish government, and which is our main subsidizing partner. If we look at the integrated policy on quality of care in Flanders, then you see that there's our three main pillars, which you all already also know, which is accreditation by JCI, by Qualicore, by others, international institutes, for the whole of the hospital, for healthcare organizations, or for healthcare programs, care programs, for labs, ISO certification, etc. There's this part which is an important pillar, and there's of course the other part in the center, which is on inspection, the inspection model of the government itself. And then there's the third pillar, which is also crucial and important, and it's viewed as one of the three main pillars of quality of care in Flanders, this is quality indicators. And for this aspect, quality development of quality indicators and facilitate public reporting, the Flemish Institute for Quality of Care was institutionalized. And of course, we want to have a good coordination and stimulate integration between these three pillars. This is still a work in progress, but we want to stimulate that inspection also uses indicators to inform them before they go through an inspection. We also want that we look at the references of inspection to develop new indicators and to support engagement on that. And we, of course, accreditation institutes should look at also our indicators or quality indicators itself to agree on accreditation or not. And valid indicators have a crucial role to play in the dynamics between these three pillars. We are ambitious. We are currently working in the four sectors in Flanders healthcare, where our main focus still is on acute hospitals and also mental health care. Also, the most experience on developing quality indicators is in these two sectors. And now, for the last 2 years, we are also looking at quality of care in residential elderly care institutes, and this will be one of our most important focuses for the upcoming years. And also on primary care, multidisciplinary care, population management is also a focus within VIKZ. And you can see VIKZ is in the center, so we are supporting these sectors in developing quality of care and mainly developing quality indicators and facilitating public reporting. These organizations or these sectors, they all have an agreement with VIKZ. They organize themselves into an association that have an agreement with VIKZ and endorse, of course, the statutes of VIKZ and the basic principles. That is, measuring quality is one of the bases of a conscious quality policy, and public transparency, public reporting is the norm. Everything that we want to develop or that we develop has the aim of publicly reporting and informing civilians on the quality of care in Flanders. VIKZ was consolidated in the governmental agreement in 2019. The position of VIKZ and the position of indicators was further consolidated in this agreement. As you can see, I will not go through all of these statements, but you can see that to be financially accountable and accountable itself, we need to focus, or the healthcare organizations need to focus on outcomes in terms of quality, and valid quality indicators play a crucial role in that. VIKZ is the central institute within Flanders to develop and validate these indicators. Quality should be measured and published, and we need this on a central platform, and this is then the platform of Zorgkwaliteit.be. And healthcare inspection and administration should use these quality indicators as developed by VIKZ for their objectives also. So you can see that the role of VIKZ is further consolidated in this agreement, and also will be further consolidated and strengthened in the new quality decree, which is now being developed. Some history and some realizations, as I mentioned. VIKZ has been operational since 2019. January 2019 was funded or was organized, set up in 2017, and then has a tradition of the VIP Quadraat quality projects, which were all implemented within VIKZ in 2019. And then you can see some other important historical moments and realizations. With them, since 2020, also the inclusion of residential healthcare and also primary care. We have a team of 6 FTEs, which will be increased in 2022 with 3 additional FTEs, full-time equivalents, with the focus on data and data analysis and coordination of projects within the different sectors. As you can see, our governmental board is consisting of sectoral, but also governmental representation and representation of the different sectors, but also representation of patients in patient platform and the healthcare sector, and also the mutualiteit. And also the federal government is involved within the VIKZ governmental board. If you look at the governance structures, then we have a very important monitoring committee that assesses all the indicators that are developed and initiatives on its validity and reliability. and ensures that the quality indicators have been developed according to the scientifically sustained methodology. This monitoring committee, and this is also a very important role, is also responsible for overseeing data protection and information security procedures. And next to this monitoring committee, also a very important board within VIKZ is the Scientific Advisory Board, which functions as a knowledge platform within VIKZ, in which all the experts and universities that are active in the field of quality of care are included, and oversee also all the developments of VIKZ. So these are two main governance structures within VIKZ next to the team and the governmental board. Then we have per sector, so for acute hospitals, primary care, elderly care, and mental health care, we each have a board per sector, in which you can see then also the sector and government is involved, and also scientific institutions are involved to support decision-making within this sector. They are responsible to ensure sufficient support in the sector, to determine the domains in which quality indicators are to be developed, and to monitor the status and results of the various initiatives and development groups. And next to these, at the lower level and lowest level, there are development groups per sector, but also transversal through the different sectors. For example, this is then one example of the development group of thoracic oncology, in which quality are developed with the experts itself during a decision process and development process. In addition to this, to these development groups and to the boards and to the different boards per sector, there's also a forum such as this initiative, where we communicate, which we use as communication channel to these sectors. So you see, VIKZ is not only the VIKZ team, but VIKZ is a network organization in which various people, persons, and boards are involved, and which all support or try to support and coordinate these initiatives with all the various experts in the field. If you look at quality of care and indicators, I don't think that I need to define quality of care itself. I'm sure you know quality of care is a multidimensional concept in which we look for effective efficiency, safe, timeliness, patient-centeredness, equitable of care. If you look at our current initiatives, then they are mainly focused on effective, safe, and patient-centered. Other quality dimensions are not yet in the scope of VIKZ, but maybe they can become in the scope for future developments. Quality indicators itself, of course, they are standardized, evidence-based to measure performance, and they can be divided in structure, process, and outcome indicators. And our focus is here mainly, of course, on outcome and process indicators. Outcome indicators themselves to inform or to support informed choice for Belgian or Flanders, Flemish citizens and patients, possible and potential patients and family. There are outcome indicators, but also process indicators to inform also patients, but mainly institutions, on how they can improve their quality via benchmarking, for example, of process and outcome indicators. Structure indicators are not within our scope, but we see that to develop process and outcome indicators, sometimes we go through the development of first structure of policy, quality policy at first, and then to develop from these structure indicators also process and outcome indicators. So they are sometimes involved in the structure indicators in the development of process and outcome indicators, but they are not our focus. And of course, if you look at what conditions there are for quality indicators and evidence-based, and what is the evidence-based methodology for development of quality indicators, then first, if you look at the conditions, we of course want to have an impact. Yeah? We want to have an impact on quality of care. We want to have an insight in how the institutions and caregivers score on quality of care. We want to use these results for benchmark to stimulate internal improvement and to stimulate also positioning of your organization, healthcare organization, with your peers as means of benchmarking. And for this, we need indicators that this sounds very logical. But isn't that at all. We want to have indicators that actually have an impact on quality of care. This is also, of course, the biggest difficulty to have also measurable indicators and which are also feasible to measure. And we try to start and connect with all already available data, but not always are data available, and sometimes we have to implement uniform registration policy as first, and then come to an indicator and come to a measurable and feasible initiative. And of course, reliability and validity is also very important, and timeliness of data, which is still a very important challenge within Flanders, and not only within Flanders, but also within Belgium. Timeliness of data is very important to use these data for means of quality improvement and public reporting. These indicators must also have a potential for improvement. If we know in advance that the scores on the results on indicators are high and are mainly high and will stay high, then we have to consider if these are still good indicators to measure. There must be some progress possible and some variation in scores, not only within healthcare institutions or healthcare organizations, but also between healthcare organizations to stimulate, again, quality improvement. And because we want to also stimulate public reporting, these indicators and the results on these indicators must be relevant and understandable and visually dynamically understandable for patients for the means of public reporting. If we look at our methodology, then we have 7 phases. This is also published on our website, so you can read this publication. It is in Dutch. Still, we still have to translate it, but it is in Dutch. But these are the main phases and steps for other developments. Also, it's also some kind of PDCA cycle in which you first look and identify your goal. Then develop the indicator itself with an expert panel, of course, and also look at selection with this expert panel for which indicators you want to follow up, which are feasible, measurable, reliable, valid, and timely. Then you define these indicators, you define your measuring procedure, and you pilot the first you pilot your measuring procedure and your indicator definitions within some healthcare institutions. You critically evaluate the results, and then you go back through your monitoring committee, you validate the whole process, and then you can start with the effective measurement of. And this process, this is a very important process, but this process can take 1 year or more, sometimes 2 years, to actually start from an intention of an indicator set through the actual development and then the implementation and public reporting of the results. This can take 2 years, or actually sometimes even longer. So this is a very time-investing procedure. But it's also important to have this input from the sector itself and from the evidence-based society also, of course. Then, well, if you look through this development phases, there are also different decision support or decision-making processes, which is divided into 3 main phases. The first phase is the development of the quality indicators and the measuring procedure itself, in which these several governance structures all have their specific role and task. And again, this phase ends with or begins with a project plan, then a definition of an indicator and an indicator set, measuring procedure, and then ends with the definition of the indicator, which is validated by the monitoring committee of VIKZ. The second phase then starts with the pilot, in which you want, of course, enough participation in this pilot by, for example, 20 or more institutions in Flanders, where you measure, you test your project plan, you measure your indicator sets, you test your measuring protocol, you make feedback reports to the organizations, look at the whole process, and then again validate this by the monitoring committee. The next phase is then again to actually start measuring, effective measuring, where again you input or you collect data, you analyze data, you deliver feedback reports. These data are always to be confirmed by the sector and the healthcare institutions themselves. And then you go back through the monitoring committee to validate the measurement and then to publish on zorgkwaliteitsindicatoren. This is our website. It is our website since 2016, and in 2022, so this year, we are developing a whole new platform where we want to facilitate public reporting, but where we have some supplementary goals with our website. For now, you can there are indicators on patient safety, patient experience, and breast, lung, and rectum cancer for the acute hospitals, and for mental health care for patient safety, patient experience, and treatment plans. And since September 2021, we also published, measured and published vaccination rates at acute hospitals, psychiatric hospitals, and residential care. You can see an overview of our most important publications, but I want to focus on the results themselves. Here you can see some of our results and the evolution we see through the years of measurement on, for example, the patient safety indicators. This is an example of the indicator that measures basic recommendations for hand hygiene, which are external audits that take place within the hospitals and within psychiatric hospitals. And here you can see the results in a box plot, visualized in a box plot, where you can see that there was some large distribution in results, where you can see that in the past years, this distribution of variation tightens, became smaller, and you can also see that the median scores improved and improved to more than 90%, in which these basic recommendations were actually found in the healthcare institutions. You also see these results for psychiatric hospitals, where there are still some important challenges on hand hygiene. These results date from 2018, 2019. Why? And these results or these measurements require external audits, and due to COVID-19, these external audits were not feasible or were not possible to do. But this year, we hope in a couple of weeks to start a new process of auditing in the Flemish hospitals. Another important indicator is patient identification. Well, you can also see here, that's also important to see, is the number of hospitals which are involved in these measurements. And you can see that mainly all Flemish hospitals participated. You can see an evolution within that, but we can say mainly, apart from maybe sometimes one or two hospitals, mainly all hospitals participate in these indicators. For patient identification, again, you can see the results. Each point is a hospital. You can see the distribution of results in a box plot, and you can see that these results also improved during in the past years. And this is not only on public reporting. This is also as a result of accreditation. But you can see that these results improve. We can follow up these results through the years on hand hygiene and patient identification. Also, patient identification is an external audit which is organized within all hospitals. Then a new indicator, or not actually another very new indicator. This is an indicator has been in development for now about 10 years, but now we actually succeeded in developing a reliable and valid indicator set for unplanned readmissions based on MZG data, minimal data sets, hospital data, and IMA data, financing data. But, and we now have also this viewpoint within acute hospitals, and again, within almost all acute hospitals, on unplanned readmissions up to 2020. And next year, we will monitor these results further. And you can see again a large distribution in results. These percentages are mainly also the results that we see in other in evidence-based literature, and these are on classical hospitalization, but also on surgical day hospitalization. And you can also see evolution on individual hospital levels. So these are all hospitals. Every point, every dot is a hospital. The dot is the first time this indicator was measured, and then this points to the last result. So the last result of 2020 and the result of the first measurement of 2018. And then you can see an improvement. An improvement is down or a deterioration in result per hospital. Also for the two sets of indicators. We also look at an important domain is patient experience measures, in which we use the instrument developed by the Vlaams Patiënten platform, in which we can look at results now of a couple of years of measurement. And again, you can see large participation within this domain. And you can see also the evolution, where this color is a deterioration of results. This color is a significant evolution, positive evolution in this result. And this is an evolution, but not a significant evolution in this result. And then you can see also that, for example, worst scores are on information on costs, the way patient can participate in decision making, and the way caregivers present themselves, introduce themselves to the patients. And mainly positive results are on information, but also on, is the patient ready or not for discharge? Does the patient receive adequate information on treatment, etc. So you can see measures, you can see distribution, you can see evolution in results, and you can see participation. And also this evolution of results you can see on every individual participating hospital, with again the same visualization of the first measurement, the last measurement, and the evolution of this hospital. Another domain is on lung cancer, where we have several indicators, and we work closely together with the Cancer Registry Institute, where we have indicators on registration of clinical stadium, pathological stadium, WHO performance status, cell and tissue diagnosis, where we have target results. These are the target results that are defined with the experts. And then these are the results of each hospital, again, visualized in the box plot, where you can see, again, a large distribution in the results. These are important indicators, but of course, if these are also very important indicators, which are corrected relative mortality risks at 90 days post-op, at 60 days post-radiation, and 1 year post-diagnosis. And again, you can see the results. Higher than 1 is higher than average mortality rate, and you can see the distribution. And here you can see another visualization of the scores of each hospital on this indicator. On this indicator, observed relative mortality rate of 1 year after the diagnosis. And you can see that if the confidence interval of a hospital is outside of or above or below 1, then there's a significant difference. So this hospital, for example, the mortality rate for lung cancer after 1 year post-diagnosis is significantly higher than in the average Flemish hospital. And in this hospital, for example, and others here also, you can see that the mortality rate is significantly lower than the average hospital. You also can see what is also important to see here is that there was no, so all hospitals are ranked with the highest hospitals on this right, the hospitals with the highest patient volume from left to right. And you can see, for example, that there is no, within these results, no significant relation between mortality rate and patient volume per hospital. But you can see that the confidence intervals, if you have higher patient volume within your hospital, these confidence intervals become smaller, and thus your results are more reliable. You can see this, for example, this hospital, which is UZ Leuven, which has the lowest mortality risk for lung cancer. Then a new domain, we were asked, such as all regions within Belgium, we were asked to develop an indicator set for vaccination rates for COVID-19. We asked in July 21. We developed this indicator together with the Knowledge Center, together with Cienzano, and also together with the participation of PAX. And we now have also here a relatively high participation rate. For example, almost all hospitals and all psychiatric hospitals participate. And also 67% of the elderly care facilities, nursing homes participated in this, which was a success. Because for the nursing homes, this was the first time that they collected and publicly reported quality of care on an indicator for quality of care. Here you can see the results from September to November. We are currently making an update on these results with the booster vaccination included. And you can see again, dots, same visualization, dots are hospitals. You can see box plots with the results. You can see the target result, which is laid out on 95%. So we expect 95% of these healthcare workers, personnel within healthcare institutions to be vaccinated. And you can see here some main results also. And you can see some distribution, and within the elderly care facilities, the highest variation, where there's still some in nursing homes that have a lower than 70 or 80% vaccination rate in December 21. We were also able to look at function groups. We can see that there's also some challenges for specific function groups. Again, you can see the status of the booster vaccination in December 2021, where these results, of course, the booster campaign was still ongoing at that point. I can see that there was still some work to do within the healthcare institutions. Okay, so these are some results where you can see the evolution also in the results and the visualization of our results. And these results are published on zorgkwaliteit.be. As mentioned, we have some objectives with our website in 21 and 22, where we want to enable also public reporting and other sectors of the VIKZ. So, for example, in residential elderly care and also for primary care, as well as making quality visible not only on the level of an individual organization or organizational level, but also, for example, on campuses, on networks, on primary care zones, regions, to make quality of care visible on other levels of care. And of course, with our new website, we want to increase our impact by improving usability, accessibility, visualization of our results. And this not only for all types of users, which are healthcare facilities, institutes themselves, but also patients, citizens, general practitioners, and policymakers and researchers. Here you can see an overview of, I will not present these, but this is an overview of the indicators that are running now, that are in development now in the different sectors, and that are in development or that are in the pipeline of development in the next coming years. Where you can see, for example, the focus on infection prevention, of course, due to COVID-19, but also, for example, on PROMs for oncology. And also an important goal objectives is to, which will be our main focus also in the next year, on PREMs for elderly care, PREMs in elderly care facilities. Okay, now if we look at to conclude, if we look at what we have done now, we have focused on outcomes and process indicators. Of course, we want to stimulate patient value and value-based healthcare. And our main focus was, of course, on this second objective to measure outcomes, costs. We are not focusing yet on costs for every patient, but we are focusing on processes and outcomes. And we want that these indicators and these results are also publicly available and used for other domains in quality decision-making and development. For example, if we want to develop within VIKZ, we want to also look at other types of indicators. So not only the outcome and process indicators, but also these indicators that are perceived by the patient. So PREMs we are already measuring, but not PROMs. So we want to look at also, PROMs are also an important objective within VIKZ, to not only look at survival, for example, after lung cancer, but also degree of health, time to recovery, pain, complications, etc., quality of life, of course. We want to see if we can stimulate also development in this, and not for and to be clear, not with the objective to benchmark or publicly report, no, but to where our central objective is to conduct or to stimulate implementation of PROMs and PREMs within the Flemish healthcare sector. And for this, we have also a research study funded by Kom op tegen Kanker with these partners, also to promote structure embedding of PROMs within Flanders. So this is a research project. And then, of course, we are also looking at new types of indicators visualized on different levels of care, for example, regional care, not only for reasons of quality or quality improvement, but also as input for population health management. These are also some indicators, for example, and we look, for example, at a very good example of in Sweden, Flandre is where they developed more than 700 indicators, not only on specific quality of care and not only for reasons of public reporting and benchmarking, but also for reasons of population health and policy on that. So this will also be a focus for VIKZ in the upcoming years. Voila, this is my presentation within the time or on the border of the time. So I'm looking forward for if there are still some questions on this.
Yes, so thank you, Svin, for this very thorough presentation. So there has been 2 questions in the chat, and I also have two questions for you for the last 11 minutes remaining. So one was from Rui from Portugal, that was questioning when you were talking about the 3 pillars, quality indicators, inspection, and accreditation. His question is more, how do you comment on European countries that are kind of stopped recognizing accreditation and more focusing on quality indicators and quality improvement strategies?
Yeah. So we also see this evolution within Flanders, where all healthcare institutions are accredited since now, but also a lot of healthcare organizations are now considering if they want to further be part of this external accreditation process by external institutes, international institutes, for example, of JCI. We also have, we have initiatives in development within Flanders where we look at alternatives, alternative processes. And of course, VIKZ is mainly focusing on that one pillar, quality indicators, where we believe that considering all types of new developments that there will be in quality policy, in accreditation, in inspection by governmental inspection, quality indicators will stay or will still have an important and a crucial role. So in all the developments that we see, quality KPIs will still have an important role to play. So thus we will still invest on these. If you are internationally or externally accredited or not, you want that healthcare institutions take responsibility to show their results, to publicly report their results on quality indicators, and this is possible via the VIKZ.
Mm-hmm. Thank you. Another question was more about the types of indicators. So we talk about structures, processes, and outcome measures. There was something about, is it outcomes or outputs? Because Paul Bachelor told me that in acute setting, it's more about having outputs and outcomes. So why focus on outcome measures and process measures?
Yeah. If you want to stimulate quality improvement, you can not only look at outcomes. Outcomes are of importance, for example, to stimulate benchmarking, to stimulate external use of the data, to stimulate also informed choice for citizens, but they are not enough. So to actually learn something on your process, on how to improve, you also need to look at process indicators. For example, we do have now a new domain within VIKZ, which is on a stroke, of course, that's STEMI and stroke. If we only look at for stroke mortality rate within 30 days, within 1 year, and you do not look at, for example, door-to-needle time or screening or other screening methods, well, then you never will learn or antibiotic use or infections, other outcome indicators. You will not learn on how you are able to improve. So you need to focus on both, and also you need to develop structures. You need to develop procedures, but that is not our main focus. Our focus is not on developing structures, on procedures. Our main focus is on process and outcome indicators.
But the structures are implicit because you need them to put in the processes and to get
yes. And sometimes we do not have a structure. So then we need to, with the sector, also look at developing procedures, developing uniform procedures.
Great. I do have questions. I'm just going to launch the evaluation for those who are still there. I had one question. So depending on the quality indicators you're using, how does the data get to you? You have a contract and you define a procedure for each quality indicator, but how many times does it get published or sent to you? Could you explain a little bit about that? How does the data get to you?
Yeah, this of course depends on the indicator. For example, on the PREMS on the patient experience measures, these data, these surveys are taking place two times a year, and then they are sent to us also 2 times per year. We develop reports on them, feedback reports, and we publish them once a year. For other indicators, for example, for lung cancer or oncology, there we have agreements with the Stichting Kankerregister, with the Belgian Institute for Cancer Registry, and this is also a development process where they collect the data registered by the hospitals in this for this sake. They then make feedback reports together with us to the hospitals. These data are then confirmed by the hospitals, and these are published. And this process, because this is all based on secondary databases, not on the primary databases. This is based on secondary databases. This is a very time-consuming procedure. This takes 2, sometimes 3 years, for which you have the actual data and then can publish. But now we have, for oncology, for example, we've chosen not to develop new indicators for new domains. No, we chose to monitor existing indicators so that we can quicker develop new results and publish new results.
Okay. Thank you. There's one new question. How do you monitor the data? Wait. So the question is about the data being used, I think, in the institutions themselves. Does the data feed into the management of an institution in a positive way? How do you have any insight on that? And for instance, how do you use good results, so good practices? How is it the learning community, or is it just quality measurement at this point? And will it be?
Yeah, that's a very good question. Again, we started up in 2019. It's now 2022. Our main focus stays and will stay also for the upcoming years of producing quality results, quality measurement, and stimulating quality measurement. And then we of course have collaborations with other institutions. We have collaborations with the government, and we have with the healthcare institutions itself, where we try to stimulate also learning. But this is now and will still be a secondary focus. Our main focus is now on developing indicators and publicly reporting. But if you look at the results on the indicators, of course, you can see if we measure these indicators, we develop insights on which you as an organization can see where you can improve. We can stimulate also with publicly reporting these results. We stimulate improvement. You can see that in our results. And I do not want to say that this is mainly the result of public reporting. This is also not mainly the result of accreditation. This is not only the result of local quality improvement initiatives. This is a combination of all these this quality working in which you can see positive results. Not always, but we see these results on patient experiences, on patient safety indicators. We see these positive results.
Thank you. And I have maybe one last question for the last two minutes. So you mentioned a lot of times in your presentation that you support the sector. I hear it's just producing quality data and putting it publicly. What does this support then represent? Is it more supporting the members of the sectors who are part of your boards to identify the best indicators, or do you go a little step further with actually organizing, I don't know, sessions or support in another way?
Yeah, so mainly the support is again on supporting the sector, on developing reliable, valid indicators, relevant indicators, which themselves, in the sector themselves, and the experts see as reliable and relevant indicators. And then, of course, we support the sector in giving and presenting them the results in feedback reports. Also, we support the sector in benchmarking these results, and then we try also to support, this is work in progress, but on a learning network, by developing learning networks on these indicators.
Thank you. I see there's no further questions. It's almost the top of the hour. So I would like to thank you for taking the time of presenting the work that's being done in Flanders, in Belgium. And thank you a lot. Okay. There's a lot of positive feedback.
It's also very transparent to see the scores on the.
Yeah.
So I'm perfect.
We're all about transparency. So you can see a good feedback. The chat is also giving you a lot of congratulations. So thank you, Svin. And for the others, we'll see you again in the next quality and safety webinar. So thank you. Have a nice afternoon.
Bye.
Bye.